68-year-old woman exertional right knee pain, obesity, and type 2 diabetes examination shows crepitus without swelling. Diagnosis: likely knee osteoarthritis, OA. Treatment recommendation: first-line treatment is topical NSAIDs, specifically topical ibuprofen. Additional notes: intra-articular steroid injections. Oral medications like codeine, ibuprofen, and paracetamol are not recommended as initial treatments. Osteoarthritis symptoms: the patient presents with knee pain that worsens with activity and difficulty opening jars at night, indicating hand osteoarthritis affecting the carpometacarpal and distal interphalangeal joints. Osteoarthritis features: commonly affects women, often bilateral, episodic joint pain, stiffness after inactivity, and painless nodes like Heberdin's and Bouchard's nodes. Investigations: X-rays show osteophytes and joint space narrowing, often before symptoms develop. Management includes weight loss, muscle strengthening exercises, topical NSAIDs, and possibly surgical options if conservative treatments fail. Short-term relief: treatments provide relief for 2 to 10 weeks. Joint replacement considered if conservative methods fail. Gout mechanism: mostly due to decreased renal excretion of uric acid. Medication impact: thiazide diuretics like indapamide can precipitate gout by reducing uric acid excretion. Limited cutaneous systemic sclerosis: this form involves skin thickening distal to the elbows and is associated with anticentromere antibodies. It can lead to late-stage pulmonary hypertension. Diffuse cutaneous systemic sclerosis: this form affects the trunk and proximal limbs, associated with anti-SCL70 antibodies, and often leads to respiratory complications like interstitial lung disease and pulmonary arterial hypertension. Around 2% of women and 6% of men with Raynaud's phenomenon develop systemic sclerosis. Scleroderma: this involves skin tightening and fibrosis without internal organ involvement, manifesting as plaques or linear forms. Risk factors for osteoporosis: advancing age, female sex, glucocorticoid use, rheumatoid arthritis, alcohol excess, low BMI, smoking, sedentary lifestyle, premature menopause, and certain ethnicities, Caucasians and Asians. Secondary causes: endocrine disorders, gastrointestinal disorders, chronic kidney disease, and certain medications, SSRIs, antiepileptics, proton pump inhibitors, glitazones, long-term heparin therapy, aromatase inhibitors. Investigations for osteoporosis: history and physical examination, blood tests, full blood count, urea and electrolytes, liver function tests, bone profile, CRP, thyroid function tests, bone densitometry, DXA, and other specific tests if indicated. Raloxifene prevents bone loss, reduces vertebral fractures, may worsen menopausal symptoms, increases risk of thromboembolic events, and decreases the risk of breast cancer. Granulomatosis with polyangiitis, GPA, involves granulomas and vasculitis, affecting blood vessels but not typically associated with ear involvement. Reactive arthritis, triggered by infections, presenting with arthritis, conjunctivitis, uveitis, and urethritis cervicitis. Nasal deformity and ear involvement are not seen. Relapsing polychondritis, a multisystemic condition with inflammation and deterioration of cartilage, affecting ears, nose, joints, and respiratory tract. Key features include auricular chondritis, nasal chondritis, and ocular involvement. Pseudogout, associated with hemochromatosis, presenting with acutely swollen and painful joints, particularly the knee. SLE. The strongest associations are seen with HLA-DR2 and HLA-DR3. SLE has a higher prevalence in non-Caucasian populations such as African Americans, Hispanics, Latinos, Asians, and Native Americans. More common in Afro-Caribbeans and Asian communities. Female-to-male ratio for SLE actually ranges from 6:1 to 10:1 depending on the population studied. Typical onset, usually between 20 to 40 years of age. Incidence has increased threefold over the past 50 years according to the American College of Rheumatology criteria. Pathophysiology. Autoimmune disease. SLE is an autoimmune disorder. Hypersensitivity reaction. It is classified as a type 3 hypersensitivity reaction. Genetic associations linked with HLA-B8, DR2, and DR3. Cause, thought to result from immune system dysregulation, leading to the formation of immune complexes. Organ involvement. Immune complex deposition can affect various organs, including the skin, joints, kidneys, and brain. Rheumatoid arthritis in pregnancy cases. Hydroxychloroquine safe during conception, pregnancy, and breastfeeding. It does not increase the risk of congenital defects or adverse maternal or fetal outcomes. Sulfasalazine and hydroxychloroquine are considered safe in pregnancy. Methotrexate teratogenic should be discontinued at least 6 months prior to conception and not used throughout pregnancy. NSAIDs should be avoided in the 3rd trimester due to their potential to cause premature closure of the ductus arteriosus and oligohydramnios. Early or poorly controlled RA should be advised to defer conception until their disease is more stable. Discoid lupus erythematosus, DLE. A benign autoimmune disorder that primarily affects younger females. It rarely progresses to systemic lupus erythematosus, SLE, with less than 5% of cases making this transition. Characteristics. Follicular keratin plugs. These are a hallmark feature of DLE, where keratin accumulates in hair follicles, leading to the characteristic skin lesions. Autoimmune etiology. The body's immune system mistakenly attacks its own tissues, causing inflammation and damage. Features. Rash. The rash is erythematous, red, raised, and sometimes scaly. Photosensitivity. The rash may worsen with sun exposure. Common locations. The rash is more common on the face, neck, ears, and scalp. Healing. Lesions heal with atrophy, thinning of the skin, scarring, and pigmentation changes. Scarring alopecia, hair loss, can occur if the scalp is affected. Management. Topical steroid cream. This is the first-line treatment to reduce inflammation and rash. Oral antimalarials, used as a second-line treatment, such as hydroxychloroquine, to manage symptoms. Sun protection. Avoiding sun exposure is crucial to prevent flare-ups and worsening of the rash.